We are live now, doctor.
Yeah, I think Syed has joined. Yes, Chitra, start. Yes, Chitra.
Good evening, everyone. I welcome you all to this felicitation ceremony. May I request Dr. Naresh sir to please introduce about the session and welcome all the panelists, and we'll start the session. Dr. Naresh
I
sir,
will
please.
take care of the panelists, Chitra.
I'll take care, sir. I'll take care.
Okay, yeah.
Yeah.
So again, I think this will be the 10th or 11th episode of our felicitation. So we would like to welcome all the contributors and also all the panelists. And as we have been telling, actually, we don't have any copyright over these images. Please send as much images as possible. If you have got anything except in any other journal, you can always withdraw from this certain issue. And to all the the participants, please don't thank anyone straight away. You start with your case because you'll be having only 2 minutes to present, and I think it will be moderated by Chitranjan, who will be calling the panelists so that they'll be giving their opinion. Over to you, Chitra.
Thank you, Dr. Naresh sir. In this felicitation ceremony of VRSI image competitions for the month of October, November, and December 2025, we have panelists who are renowned retina specialists of national and international repute. We have Dr. Abhijit Chattopadhyay from Kolkata, Dr. Syed Mohiddin Abdul Qadir from Tirunelveli, Dr. Rima Bansal from Chandigarh, and Dr. Gajendra Chawla from Bhopal. They don't need any introduction at all. So, with this, we'll go straight away to the winners for the month of October 2025. The third prize for the month of October 2025 goes to Dr. K.R. Chakrabarti. Congratulations, Dr. K.R., for this award. And this is the award-winning image with title Retinal Capillary Hemangioblastoma Status Post TTT in a patient with VHL. And this is the description Dr. Kea has given for this image. Dr. Kea is from Arvind Hospital, Madurai. And may I request Dr. Kea to please describe this image, after which we'll go to the panel for the discussion. Dr. Kea, please.
Sir, good evening. A 48-year-old female came to us with a defective vision. On examination of the left eye, we could see that the disc was normal. There was dilated vessels over the superior arcade. We can also see multiple capillary hemangioblastomas and also exudation in the superior arcade. Exudation has also, you can also see the exudation near the macula. The scarred lesion that you can see beyond the superior arcade is a regressed hemangioblastoma following transpupillary thermotherapy. This was a unilateral presentation. Patient came with only one eye having retinal capillary hemangioblastoma.
Okay, yeah, very nicely treated. Any systemic association, anything you found for this patient?
This patient did not have, sir. We had sent to neurologist to rule out CNS lesions, and also ultrasound abdomen and all were taken, but this patient did not have any systemic association.
Okay, good. So now we'll go to the panel for this. May I request anyone from the panel, Dr. Rima, and Dr. Gajendra sir, Dr. Syed sir, or Dr. Abhijit, anyone please comment on this lesion and the imaging skill.
So, congratulations, Kaya.
Thank you, ma'am.
Is this Clarice?
Yes, ma'am.
Okay. So, very nicely documented. My one question is, did you diagnose at one go looking at the hemangioblastomas, or did you have to do a fluorescein angiography, or, I mean, they look obvious, but sometimes when you in a busy clinic, you see these lesions and you think of a lot of vascular pathologies. So, was your
Yeah.
diagnosis straightforward?
BHL was suspected, ma'am, but we did an FFA to be safe.
Okay. So you treated all the hemangioblastomas. I mean, we can
No,
see
ma'am.
people.
Oh, sorry. Only the superior one, ma'am. The other ones were too small. We had planned to treat, but patient was lost to follow up. Actually.
Okay, madam is asking any other indication like you had fluid at the center of the fovea or anything like that? What prompted you for this thing? Or in other words, if it would have been little more, peripheral, should we go for this or not? Any
Oh,
comments on that?
unless the patient was symptomatic, he had SRF and exudation. That is why we went ahead with treatment. Otherwise, it would have just been observation.
Correct.
Mm.
So, any other comments from any panel?
Hello, I am Dr. Abhijit. I just want to say that you treated nicely, and but the yellow, the exudates and the subretinal submacular exudates also, I think it will be causing a decreased vision. So better you would have treated the smaller ones with maybe argon laser also, and the associated with the scar you can see is not fully gone basically. It's down but not out. So it may create problem later.
Yes, sir.
But photo is nice. Congratulations for the win.
Yeah. So thanks Abhijit sir for the nice comments. Here we come up with two things. One is the exudates persisting, and second is TTT versus say grade 4 laser in the traditional argon laser, whatever we are doing. So any thoughts on this from any other panel or Naresh sir?
Like Chita, I think in this case we have done, I think, green laser only.
Yes, sir.
But we have got the experience of surgical thing also. But in some cases there will be ERM formation. In those cases we have done ERM peeling also. But only thing is you have to take a complete family history, because we have had 3 or 4 families with almost all the members affected by this one, and many people losing their life quite early.
Mhm.
So I think we have to go for a thorough family screening in all these cases.
So point is very well taken. All these patients, it's not just the eye, we are treating the body or the system as a whole, and not only with the patient, but also the other family members. So just if I want to just expand the question further, sir, TTT versus green laser. So which one will prefer, and any other preferences?
Not many people will be having TTT, but we prefer TTT.
Okay.
So do you have any rule of whether you consider the size? If the smaller tumor can be treated with a laser and the larger will require TT or something like that?
No, sir, periphery we go for cryo usually, but if we are not able to reach, even after peritomy and bridling, I think usually we go for TTT.
So size is small, then can we treat with the laser directly?
Possible, I think.
We can.
Yes. Okay. Good.
One
So
of
we
the
had a
other
very, yes, sir.
instead of the temporally, there are multiple large aneurysms also there. So should we treat that lesions also?
Yes, yes, yes.
I think we should. Yeah.
Yeah, that's what KI told also. They were planning for this, but the patient did not come for the laser, it seems. They planned for treating these aneurysms also.
So we'll move on to the next one.
Yeah, thank you everyone. We had a nice discussion on this. Again, congratulations, KI, to win the certificate and 2000 rupees for this beautiful image. And of course, the nice management you have done. So with this, go to the second winner, Dr. Srinivas Telkikar. Dr. Srinivas is from Sankarai Hospital, Simoga, and this is the award-winning image, Uncommon Companions. That's what he has captioned it as. It's a case of proliferative diabetic retinopathy with MacTel. This is the description Dr. Srinivas has given for this. May I request Dr. Srinivas to please describe this image. Dr. Srinivas.
Good evening. Good evening.
Good evening.
Hello.
Yeah.
Yeah, go ahead, go ahead.
Yes, sir. This is a 62-year-old male, sir, with PDR with MacTel, and he undergone past PRP3 settings. Then on Octa, there was cross-sectional Octa, there was epiretinal tissue, which showing flow signals, which confirming that this is the epiretinal neovascularization, and this is NFS Octa, which is showing branched, tangled vascular network, which is taken in the settings only. If you press the left side of the mouse keypad, there are 3 modes will be there: black and white mode, and then color mode and reverse mode. If you select this color mode, there are color grading and contrast, and then brightness. If you adjust this type of image, we will get, sir.
Which machine you told Srinivas for this OCTA?
Sir, this is DRI OCT Triton, sir. top
Clear
con.
idea. Good. Great. So congratulations. And any comments on this particular image from any of our panel? Syed sir, Abhijit sir, Rima madam.
Dr. Srinivas, very good image and very good documentation, especially that octa, that typical this epiretinal membrane you have shown. That is really rare to see, and the combination of PDR with Mactal is really very rare. So good documentation. Must congratulate about your image.
Thank you, sir.
Good. So one question to the panel: how frequently we see, or it's just association of this MacTail of PDR, which Srinivas was able to capture nicely, or any change in our management pattern when we see this?
Just in which level this is taken means this is the epithelial membrane only, and
Sir,
the
vitreous lab mode, sir. Vitreous
yeah,
lab.
yeah, but the deeper level basically for MacTail the vessels usually arise from the deep vascular plexus. So anyway, is this okay, or is there any new vascularization or anything else there?
It was there, sir, in both eye it is there, but left eye which is predominantly seen, sir, because of that epiretinal
Okay, so
neovascularization over the fovea only.
what is your plan of management here?
Sir, we actually plan, we given anti-VEGF, sir, followed by, he has macular edema along with, on follow-up, sir, he developed macular edema, so we give anti-VEGF.
The
I,
retrieval traction. Yes, madam.
Yeah.
Please.
Srinivas, I have a question for you. Do you think this neovascularization is because of Mactil or because of PDR?
Ma'am, usually epiretinal neovascularization is very uncommon finding in MacTel, ma'am. But because of the retinal ischemia and additional compromised Muller cell in PDR, this will development of foveal neovascularization in cases of MacTel, ma'am.
Okay. Could it be just a component of a taut posterior hyaloid? I mean, we can see it's causing a VMT on the OCT scan. So there is a vitromacular traction.
Yes, ma'am. Yes.
Okay. And the other eye also had this kind of VMT?
Yes, ma'am. But it is very small. It's focal only.
But this is nice because we usually see combinations of Mactil with moderate NPDRs and mild NPDRs.
So one thing regarding the MacTail and neovascularization, because PDR usually we see the neovascularization outside the center of the fovea, right above the center of the fovea. Probably that is something which is in favor of MacTail. Otherwise, as Rima madam told nicely, it can be a component of PDR itself.
The Mactil neovascularization is intraretinal.
Intraretinal, yeah,
Not subretinal.
that's against MacTail, yeah.
I would take it as probably because in many cases of TPHM, there is a membrane growing within the taut posterior hyaloid, and especially when you take them up for surgery, they bleed a lot. So that's the reason, because they have an underlying membrane and vascularization, so that's why they bleed when you peel them off. So even though it may not be very obvious, so probably this is a component of PDR.
PDR itself, correct. So maybe FFA would have given a better picture slightly.
Usually, Mactal will have foveal atrophy also. In this case, actually, an initial fovea is a little bit split up, maybe because of the neovascularization and component of taut posterior hyaloid is also taking place. That's why I think it is just kind of a little bit lifted up. Whether intramuscular injection is wise, or can we go for ad lasers in this case? Can anybody answer?
Srinivas, are you planning for ad laser? Sari is asking.
Yes, sir. We did add and laser, sir.
Okay, good. So good.
Is there any
It's
follow-up
nice.
images of it? Is there any follow-up images? Follow-up image? Do you follow up the case?
Yes, sir.
Anything in
He
reducing or
came
anything
after
like that?
one follow-up, sir. After that, he came for follow-up, sir.
Any regression of the NVE, Srinivas?
That Octa I have not seen, sir, but he came for follow-up, sir.
Okay, good. So good, we have very good image and we had a very nice discussion for this. Again, congratulations, Srinivas, you win a second prize for this image and 3,000 rupees. With this, we go to the first winner, Dr. Farhat Fatima. She is from MMJCI Hospital, Hubli, and this is the DUSN image for which she has won the prize, first prize for this. And this is the description regarding the image she has given. May I request her, Dr. Farhat Fatima, to please describe the image. Are you there? I think she is not there. In her absence, may I request again? We welcome Dr. Mahesh G. Sir. He has joined recently. Welcome, sir. Any thoughts on this duration and how frequently we see the worm? Because hardly 40-50% times we see the worm. If at all we see the worm, then only we can go for a laser. So how frequently we see, and any other takes on this particular disease entity?
Thank you, Chittaranjan. I had only a couple of cases seen on the last 15 years.
Yeah.
Sometimes we miss it like probably APMBP or something like that. We will overlook the worm.
Yeah.
That is a problem. Another thing is probably, I don't know, fundus autofluorescence is a very good. You may get this tract.
Yeah.
That is another thing that I have seen in a couple of cases. We many times we overlook it. Very carefully, you have to see the whole area so that you don't miss these small worms. I
Yeah.
have treated with laser the worm. One thing that I have noticed is even after the worm is dead, that RP atrophy and macular atrophy may be there in many cases because of the toxins probably from the worm. That is one thing. I have presented one in ASRS some 15 years back, 10 years back.
Okay.
So it is nice photo. Nice photo.
Yeah.
Sir, do you think the role of albuterol or steroids to prevent this toxicity after laser?
Actually, sir, we have given steroids also, but I have not oral steroids. I have given, but in spite of that, a couple of cases did not do well. Macula, it was only improving to 6.6 with ellipsoid loss and all. I am not sure, but steroids definitely we give because inflammation is definitely there. But I am not sure about the toxins causing permanent damage.
Usually, in all these cases, the outcome is very bad.
Yeah.
And the only thing is, while hitting the worm, I think we have to be very careful because first we have to hit the head of the worm actually and immobilize it. Otherwise, within fraction of second, they disappear.
They disappear. Actually,
Yeah, so
one
you have
thing,
to look for
yeah.
the head of the worm before hitting, and it should be a
Mm.
shot to kill it.
Yeah. One case I hit on the worm, thinking that thinking that it was head. It was actually the tail. It started moving to the opposite direction. So
Better to hit both the ends, huh?
yeah. But little difficult. It may disappear.
Yeah.
I am not sure what is the role of albendazole or something like that. In Naresh, any clue?
No, we routinely give actually.
Uh,
We routinely give anti-helminths for these cases.
mm,
And I think I have seen only one case of, even though it's a DUSN, one case of bilateral, what do you call,
mm,
Chittaranjan also will be remembering, where
Yeah.
we
yeah.
see the worm in both eyes, very
Yeah, one
rarely.
case you published the video you have taken in that Heidelberg during OCT. That small video has been taken and that is published. It seems Obuli also was one of the co-authors in that.
So mostly little, but very rarely we have seen. Yeah, Chitto, to other panelists, please.
Yeah. So, any other comments on this, Rima Madam, Abhijit sir?
I have
It's
seen.
very lucky to get two worms in a single go, actually. This picture shows two worms. Actually, it's very lucky to get like that.
Two worms in single eye.
No, is it two worms?
She
No,
has
no.
mentioned like one is mobile and another is dead worm next to that. She was mentioned in that description like that.
Okay, let's see this thing.
It's one moving here and there.
Yeah, one is non-motile fragment lying adjacent, live motile, and one is non-motile fragment lying adjacent to it.
Yeah. She has written like that. That this is, it would have been nice if she would have been present in this.
Yeah.
Hello, sir. Good evening.
Probably
Yeah, she has
near
come. Dr.
the
Farhat, we
microphile
are
area.
waiting for you.
Sorry for joining you late. Yeah.
Please describe. Yeah.
So this was a 38-year-old male, sir, who presented to us with diffuse retinitis. We could see disc edema. We could see multiple retinitis patches at the posterior pole. And at one glance, I saw something moving in the inferotemporal quadrant. So we could see a live subretinal worm that was highly photosensitive, which actively moved. And we could capture it at different times. So this image shows the motility of this worm. And there was a small fragment, probably it might be a
Is it
part
this
of that
one?
worm.
The
Yes, sir, yes.
one shown by my arrow?
Yeah. So I feel it's not another worm, it's just probably a part of that worm. It's just shed. I really don't know what it is, but yeah, there was a non-motile fragment and a motile worm.
Okay.
Was it lasered?
Yes, so we lasered it and gave albendazole 400 mg PD for a month, with followed by oral steroids. And now the patient is doing very well. He is improved to 612 vision. So it's all fine. Yeah, we could laser it. Now of almost I think it's 3 months and the worm has completely disintegrated. You can
And the
just see the little
RP
mass.
changes and disc edema kind of picture, they also
Disc
improve?
edema, yeah, disc edema has resolved, sir. There are few photoreceptors and RP changes at the macula. That's why his vision is 612. But when he presented to us, he was counting finger 1 meter. I think,
So
yeah.
my question to the panelist is, if it is microphile area, what will be the choice of their drug actually? Like they go for DEC in all these cases? How long and how much?
Yeah. Anyone wants to answer? So as far as my knowledge, sir, 6 milligram per kg body weight they give, and for 21 days they give, what I remember, DEC.
Because this looks more like a microphile area, right, Chitto?
Yeah.
Thank you.
Yeah. So, okay, sir. We'll move to the next image. Congratulations, Dr. Farhad Fatima. And this is the first prize certificate she wins for this, and 5,000 rupees along with this. Congratulations. With this, we'll move to the images, award-winning images for the month of November. The third prize goes to Dr. Neha Sudhakar, and this is a very nice image of the vitreous aquarium floating bell jellyfish endophthalmitis. This is the description that Neha has given for this. May I request Dr. Neha to please describe this image?
Good evening, everybody. Thank you for this opportunity. This is a 60-year-old male who came to us post-cataract surgery, 2 months post-cataract surgery, where he presented with anterior segment inflammation, and the posterior segment there was dense with membranes. When preoperatively I couldn't see anything. That is when I took a patient, diagnosing him as post-operative endophthalmitis. I've taken him up for pars plana vitrectomy. The media was a little hazy because cornea was not so clear. So I did a core vitrectomy and I injected intravitreal antibiotics like vancomycin and ceftazidime. Then 3 days post vitrectomy, I could have a clear picture like this, where I initially thought they were retinitis patches when I was doing vitrectomy, but later when I saw him on day 3, these were actually there in the vitreous, stuck all over the posterior pole, extending till mid periphery. So that is when I gave one more injection and all this disappeared post vitrectomy, 1 dose of intravitreal antibiotics. So this looked more like a jellyfish, which we usually see, the bell jellyfish, which we usually see in Australia and Mexico areas, where I had done scuba diving and I had seen the jellyfish. So it looked like that to me, where we could see these bells, small things on translucent jellyfish. So that is why I thought I'll describe it better.
This was a culture positive case or culture negative case?
No, the culture came negative, sir.
Chito, carry on.
Yes, sir. Now, before I go to the panel, I have one question for Dr. Neha. So, Dr. Neha is VR consultant in Sushila Netralaya, Kurnool, Andhra Pradesh. And Kurnool, sorry, sir. So, my question is, endophthalmitis cases, this beautiful images that to montage is very, very difficult. I must congratulate regarding this photography skill also. With which machine, which camera you acquired this image?
So it's a basic Zeiss Visucam 520, sir, which I've taken the picture.
Okay, great. So, okay, with this, we'll go to the panel. Syed sir, any thoughts on this, sir?
Sometimes the emulsified silicone oil also sometimes will stick to the retina light exactly. So in post SR cases also, sometimes on table you can see this kind of pattern, but this is very nice. In end of this case, it is very nice. This case, PVD is not induced completely, no? This case.
No, sir, because I thought it was in retina when I was doing, because the media was very hazy. So I didn't want to attempt PVD in this case. But later on day 3 itself, only then I got to know it's more so the exudates were in vitreous, not on retina.
Good, nice picture.
Yeah. Gajendra sir, your thoughts?
Yeah, Dr. Neha, it
You
is a
have vast
beautifully
experience.
picturized. Yeah, a very beautifully picturized image and very nice and very, I should say, it's a pleasant surprise. Even after one injection post-op, that all such debris has gone. Probably this was the vitreous debris which, because we could not induce the PVD, it was remnant of that exudate which came in the vitreous cavity, and after the injections, probably it is gone. So, do you have injected steroid also post vitrectomy?
Yeah,
The
so
second
but because
injection
the
which you have given
culture
after
didn't
surgery?
turn out anything, so I didn't inject, and it was 2 months post-operatively, so I was a little skeptical to inject steroids, so I didn't do it. But patient post-operatively, after one injection, he's at 612, sir.
Great. So again, congratulations, Dr. Neha. So scuba driving helped you in.
Chitranjan, just a closing remark, Chitranjan.
Yes, sir.
Actually, these sort of exudates are seen very commonly in endophthalmitis. It is just on the retina.
Yeah.
So either going closer to that and aspirating with the cutter is a bit dangerous, but what we usually do is we take 1 cc syringe and slowly when you flush it, actually most of this float into the vitreous and we can
Yeah.
remove. Only thing
Yeah.
is we need some patience, but these are not very densely adherent to the retina. It is just on the surface with 1 cc syringe with the BSS. When you gently flush, all of them gets, I mean, they get dislodged from the retina. That's how we used to do actually. But
Yeah.
this is quite commonly seen in most of the end of cases.
Yes, sir. 2 points from your sentence, sir.
I have, tre-
I will
I have,
highlight.
tre- I have
Gajan sir,
treated one patient. Sir,
I'll come to
Chetan,
you. 2 points from Naresh sir
sure.
saying one is gently. So all our viewers, you please take it as gently. We should not, with a Z we should hit, otherwise we may create a break. Second thing is we see it very, not very uncommonly we see, but the photographic skill, what Dr. Neha has shown over here, that is commendable. So these two are I wanted to tell. And Gajendra sir, sorry, you were telling something. Sorry, please tell, sir.
No. Actually, I have treated one case of fungal endophthalmitis post vitrectomy under silicone oil. So I removed the silicone oil and did, but there was these are the few, it was a retina was full plaster of the exudation. So as Dr. Naresh was mentioning, I tried a little bit and with the gentle removing with the soft tip needle, I could remove partially, but then since it was a culture positive fungal endophthalmitis, so in that case, I have given post-op antifungal verconazole quite a time, 3-4 injection, then I could manage that case. But as Dr. Naresh said, it should be removed very gently. And to the extent possible, should not go to each and every exudation. Yes, I have to remove this area, I have to clear all area. You should not attempt that much.
Yes, correct.
Yeah, that's a very important point. But the problem with endophthalmitis core vitrectomy is once we see a very clear retina, we feel like we have become gods and we want to give 6x vision. That over enthusiasm kills the eye most of the time.
Great.
We should know where to stop.
Stop, correct. So thank you everyone. And again, congratulations, Dr. This award to 60,000 rupees and certificate for this. And the second winner is Dr. Anjana Nair. So this is the award-winning image which she has captioned as Hell AOS Fire Twice the Sin. Sorry, Dr. Anjana, you have to pronounce it properly. I think I did not pronounce it properly. But the image is very nice as we can see over here. This is the description Dr. Anjana has given for this. And may I request Dr. Anjana to please describe the image? Dr. Anjana is from Chaitanya Eye Hospital and Research Institute, Trivandrum.
So good evening, everyone.
Yeah.
So this is a image of a 57-year-old lady who presented with the defective vision in right eye for 2 weeks duration. So her best corrected visual acuity was 6/24 in right eye and 6/6 in left eye. So on OCT imaging showed fibrovascular PED, and she was suspected to have a type 1 CNVM, and she underwent this SS Octa. And this excess octa's avascular slab was showing this very typical medusa head-like appearance. This image, which red color, is actually I had changed the mode in the image. So we have 3 modes in that: gray, hot, and rainbow. So this is the hot mode of that imagery, this is basically the avascular slab of that Octa, SS Octa. This patient was diagnosed to, even though her vision was 6/6 in the left eye, it was a very large vascular pattern, which was surprising for us. And the fundus image was actually hard exudate in macula, both eyes. And she was actually advised to undergo anti-VEGF therapy in both eye, but the patient has only undergone anti-VEGF in right eye. Since she is having a pretty good vision in left eye, she is slightly reluctant to get injections in the left eye. She's on treatment, not completed. That's the image, sir.
So
Dr. Ranjana, is it Interlight OCT or?
Yeah, yes, sir. Interlight.
Okay, fine.
Yeah. So my
It just looks like a Christmas and New Year celebration.
Yeah.
Right
Yes.
for the
No, now you have to pronounce it correctly, Dr. Anjana.
Hell's house fire, sir. This means hell's of fire, it's enough.
You. So my question is the panel that in the absence of Interlight, how we will capture this image? Or maybe Anjana also can join this. If Unni sir would have been there, probably would have given some better input. So in absence of Interlight, how to capture? It is not my question. It is all the viewers who are there. They want to capture this and also want to join the award-winning, list. Any other traditional or existing OCTA machines? Rima madam?
The HRA would get this, HRA Octa.
HRA, yeah. HRA is very nice machine. But this color thing is also...
Yeah, pseudo color will not get, I think.
The problem is...
Yeah, correct.
But
Yeah, please go ahead.
The top, there is this tritone has the pseudo color. Avanti, OptiView.
Okay.
Chitranjan, I think Heidelberg also you can get this image, but not this color. But the image
what.
you can get.
Yeah,
Yeah.
get a good membrane, but not the color. But the OptiView has the color option.
Okay.
Dr. Anjana, it's 100 years or 200 or 400 years machine you have?
Sir, I'm not sure about that, sir.
Okay, fine.
100 years what, sir? Naresh, sir, you tell us.
No, the latest one is with 100 years actually. So it's what do you call, very expensive also, much more refined.
Yeah.
And I know when I inquired, they said it's close to 3 crores for the machine actually.
Yeah.
Yeah, we can deposit it somewhere and lead the rest of the life happily.
Yeah. Abhijit sir, any thoughts on this, sir? Abhijit sir?
Yeah, it's nice photo because Heidelberg don't capture that. I take usually, but Titan I got the demo, so they are putting that software. You can capture like that. Optopolo is also very good, but you don't get the color. Optopolo anybody used?
I have used, sir. It's like a affordable machine, we can say, and but these color images we don't get in this.
Exactly. Now, Heidelberg also we don't get it.
But
Yeah.
Abhijit, this is a very high-end machine actually. There are no proper dealers for this machine in India. I think only your Bengal guy is dealing as an individual.
Okay.
I think it's Mr. Mukherjee.
Yeah. So if something goes wrong, I don't know what will happen to the service. That's the only issue.
Yeah,
People who are crazy after imaging, I think they go for this machine.
exactly.
Yeah. So for all the viewers, as people have seen, we discussed the science also and also about the imaging, skill and also some details about the machine itself. So please keep submitting. And again, congratulations, Dr. Anjana, She wins the second prize and 3,000 rupees for this beautiful image.
Thank you, sir.
Yeah. So with this, go to the first prize winner, Dr. Abhishek Nair. Dr. Abhishek is from Arvind Eye Hospital, Coimbatore, and this is the image retinal tornado, a giant retinal tear, very beautifully captured, and this is the description he has given. May I request Dr. Abhishek to please describe the image.
Good evening, sir. Thank you for the opportunity. Going to my case, this is the Optos Ultra Feed wide field retinal imaging camera image of a patient who's a 49-year-old male who presented to us with a sudden diminution of vision in the right eye, with no history of trauma, no history of any previous retinal surgeries, laser or injections. His visual acuity was hand movements, and his only anterior segment finding was he is pseudophakic, and the posterior segment finding was like he had a giant retinal tear extending from 7 o'clock to 11 o'clock position, with the whole temporal retina has rolled over and has inverted over like a flap. So we took him we made the diagnosis of a giant retinal tear with rhegmatogenous retinal detachment. So we took him to surgery next day. Core vitrectomy was done, with base shaving of the vitreous was done, and the edges of the giant retinal tear were cut and smoothened with perfluoro carbon liquid was injected. Followed by temporal giant retinal tear edges were lasered, and then fluid air exchange was done. And post-op, after 3 weeks, his visual acuity improved from hand movements to 2/60, and the retina was on with macula on, with the edges of the breaks were flat. But on post-op day 45, he came to visit again, and his visual acuity was 5/60. But here we noticed that the inferior edge of the giant retinal tear, it was appearing lifted. So we made a diagnosis of retinal detachment under the silicone oil. So we took him to OT the next day, and the inferior edge was appearing opened up due to the intrinsic contracture and PVR changes. So we made a relaxing retinectomy from 7 to 7 o'clock position, and all the subretinal fluid was drained through the posterior retinotomy, and we added endolaser burns with top-up silicone oil implantation was done. Now patient is doing well with 5/60 vision, sir, and is under our follow-up.
So again, thank you, Abhishek, for that realistic, management. My question is, the second time when you did not do silicone removal, you did the surgery under the same silicone, right?
Yes, sir. Yes, sir. And we top up the silicone oil again.
Good. Nice. So again, nice imaging skill and nice management you have done. If I ask our panel, Syed sir, your two takes on the management, surgical management of giant retinal tear for all our many young retinal surgeons are there. But Syed sir, two important things that you feel in the two steps. Syed sir?
Now, actually, we are going for that two-stage surgery, which is told by Naresh, who is
That Naresh sir will tell,
yeah,
na? Yeah.
yeah. They shifted to two-stage surgeries for this GRPs. Actually, they do well with the two-stage surgery.
Syed, your audio is slightly disturbed, Syed.
Little echo is there, sir. Syed sir, I think some. So, okay, Abhijit sir, your two important steps or advice for the young people in the management, surgical management of giant retinal tear. Abhijit sir?
Yes, initially I think, particularly if we go for this case, one is I should, what you told, but I should leave it to Dr. Norris only. But I also now practice it after talking with him. So definitely the putting the PFCL and exchanging it is good. But otherwise also I usually put about at least 2000 centistroke silicone oil. And this case, when it goes for redetachment, then there will be some subretinal PVR also. So if you manipulate under the silicone oil, and that silicone oil may go below the retinectomy to the subretinal space. So maybe it is wiser to take out the oil in case there will be some subretinal members, because whenever the PVR ages after the retinal ages in cases of GRT gets elevated, there will be so much RPs, so there will be some subretinal PVR. So better to do it maybe after taking out the oil.
Yeah. So I agree with Syed sir and Abhijit sir. Our threshold for second stage surgery, planned second stage surgery like PFCL and going for second, it has been low. Obviously, after Naresh sir's instructions and all his outcomes, because we are all from the his younger colleagues from the same institution. That's why. But I do agree that with Abhishek sir that Abhijit sir that we should better remove the oil and do it. But anyway, Abhishek and his seniors, they have managed it very nicely. And so next question is to Gajendra sir. Your two important takes on the management of Jan retinal tear for the younger colleagues. Gajendra
First
sir.
thing, before I go for that, I just want to ask Abhishek, Dr. Abhishek,
Yes, sir.
what was the age of this patient?
Sir, he is 49 years old, sir. 49.
And it was a phakic or pseudo-phakic?
He is pseudophakic, sir. Both are pseudophakic.
So I think because of the retinal tear is about 4 o'clock, we could have given a shallow encircling buccal support. Probably that will support better
Yes,
because
yes,
we are not able to do a good base shaving in the phakic eye.
yes.
So in young patient, we can think if it is less, it is around 3 to 4 o'clock hour. If it is more than that, then probably we have to sacrifice the lens and go for a complete vitrectomy. That is one thing which I could say. And yes, for the second surgery, removing the silicone oil and do a clean job and then reinsert silicone oil, that will be the probably a better option.
Yeah, correct.
Yes.
Thank you, sir. Rima, madam, your two important
I
takes.
must congratulate. The title is very catchy.
Thank you, ma'am. Thank
Abhishek,
you.
yeah, very perfect.
Thank you, ma'am. Thank you.
So, Naresh sir, two questions for you. One is regarding the buccal in GRT or the resurgery of GRT as in this case, and second is like about the planned two-stage surgery regarding this.
So
Naresh.
Chitran, this is a very ideal case for two stage. For the reason is, I think temporarily you can see the choroidal detachment also.
Yeah,
Yes.
So we can see the choroidals. So the choroidals disappear within 24 hours rather. We see after 24 hours, maybe it might be happening much earlier also. They completely disappear once we leave the PFCL inside, even
Yeah.
without draining completely. So that the reason, I mean, for PVR reduces number one.
Mhm.
And as usual, we'll leave it for 1 or 2 weeks and then we'll go for oil exchange.
Mhm.
And I don't know, resurgery, I think as everybody said, I would also like to remove the oil and tackle the membranes if at all peacefully, not under the oil. Because in case if I want to stain with tricard to look for any residual witches, or if I want to stain with the blue to look for any residual membrane, I think under what you call oil, it will be a bit difficult. Rather, it will not be possible. So I think under BSS, it will be fine. So I would like to remove the oil and re-inject the oil after finishing the surgery, but no buckle. Either primary or for the resurgery, no buckle. We completely stopped.
Correct, correct.
Yeah.
So, thank you, sir. I think Mahesh
One
sir,
of
if
my
you can.
question is, one question from everyone. How
Yeah.
to remove these eyelashes for the ophthalmologist? Is always
There is
such a
Abhishek.
beautiful image and causing the some eyelashes is causing some trouble in that.
No, one thing is important, sir. These eyelashes are the upper eyelid eyelashes. They come inferiorly. So that's what Abhishek, you could have asked young patient only. He would have definitely cooperated with you. He could have asked for a little
No,
wider eye.
Chittaranjan, now for even draping the thing I have seen, people are using a small plaster-like thing. First they put it to the, I mean, lashes, and then they are putting the, what you call the drape, and then cutting so that no lashes comes into the field. Maybe you can, we can use some taping for this lashes before we
Yeah.
take. And I think these lashes are the one which actually definitely says that it is Optos image.
Yes.
And I'm sure that Abhishek would have done some circular, cropping,
Yes,
and
sir.
after that also these eyelashes are there. So,
Yes, sir.
yeah. So, Mahesh sir, I
Yeah.
think your comments, sir, before I think you are having some other commitment also, but please, for some young colleagues, any one or two points regarding GRT surgery management.
It's always on table. We will settle it somehow. After 1 month, it will start PVR. somewhere inferiorly. So it is always a challenge. I mean, regarding belt buckle, nowadays nobody uses belt buckle, no?
Yeah, nobody.
Yeah.
Usually we try to avoid because of
Ah,
slippage and all.
this I have no experience on PFCL with that sandwich technique, but anyone has used the Denseron in inferior. See, the problem comes with inferior GRT or the GRT extending to the lower part. That area it will start PVR again. Upper part will be nicely attached. So, Naresh has used the
No,
Denseron.
actually, initially we used the problem with the Densiron is when we started using one vial was costing close to 16,000.
Yeah. 25,000
So,
almost.
and it's not available in the market also now. I think the cheaper alternative is our PFCL because that also contains perfluorooctane or decalinium Densiron 68. So I think both should be fine, I think. And
Okay.
PFCL is not a toxic thing for the retina, definitely.
Yeah. And you will remove after within 2 to 4 weeks.
1 or 2 weeks, the PFCL is replaced with the silicon oil. Now we have
Okay.
started replacing PFCL with what do you call the gas?
Air. Gas.
Gas.
Okay. Yeah.
So,
Thank you.
correct.
I
So,
think
thank you.
now our series of 96 cases are under review. I think we presented that in our VRSI Goa.
Yeah.
So we have 96 cases where we have done this two-stage surgery for GRT.
Correct. So, thank you and
Just one thing
congratulations.
that Chittaranjan sir,
Yeah.
for this buckle thing, basically we used to put buckle initially.
Mm-hmm.
Then what happened about the GRT, the edges slipping off the buckle was a big headache. So that's why we stopped basically.
Yeah.
Not that it really helps to do the base saving nicely in khaki guys also, but
Yeah.
sleeping of the edge again and again in a buckle. In fact, later on we removed the buckle on table few times when I was in Arvind that time, and then we totally stopped. Then it was life was nice basically. That's the way it came.
Yeah.
There was a time when we used to, without a wide angle viewing system, we used to operate with the Landau's lens. So after putting the buckle and tightening and putting PFCL, we used to give cryo to the periphery and then PFCL silicone oil exchange because periphery you will not be able to see. Now with the wide angle system, both the cryo and buckle are replaced.
Yeah. So congratulations again, Abhishek, and for all our viewers, you have now heard from all the seniors talking about the real life experience about GRT and not just telling that I did 6 by 6 post operatively. So this actually helps us in our clinical practice and giving good care for the patients. So again, congratulations, Abhishek. Prize and 5,000 rupees for this. With this, we go to the December month winners. The third prize goes to Dr. Catherine Jyoti, and she is from Guitar Institute, Kochi, and this is a very beautiful image. Vitreous based avulsion after closed globe injury. If you can see, actually, I zoomed it and I thought whether it is a kind of dialysis or something, but actually vessels we can see over here. So nice image, very nice image. And this is the description she has given. May I request Dr. Catherine Jovi to please describe this image? Yeah,
Good evening.
please tell.
So this is the case of a 32-year-old male who sustained a closed globe injury to the right eye 4 months back. So when he presented to us, his best corrected visual acuity in the right eye was 6.6 and 12. Anterior segment examination showed traumatic mydriasis in the right eye. And in fundus examination, we can see the vitreous space avulsion extending from 3 o'clock to 7 o'clock position. So as sir said, the vitreous space avulsion was confirmed by tracing the retinal vessels beneath the area of avulsion.
Yes.
So this can be a mimicker of retinal dialysis.
Yeah, actually, these sort of cases, the chance of detachment may be less. I don't know any. I don't have any follow up. Once the vitreous gets avulsed, there won't be any traction in the periphery, so you may not get a retinal detachment later. I don't have many cases, but this I was thinking whether there will not be any detachment after this.
Yeah.
Usually you don't get detachment, sir. As you told it, maybe that will be the case.
Yeah.
With
Traction is gone.
yeah, the scleral depression, scleral indentation helps us to differentiate basically.
Yeah.
Does vitreous based avulsion and the dialysis. But it is nice picture. The idea that to take the picture like that, that is also nice. That's why looking good.
No, it's really very beautiful. And sir, how you managed, or Dr. Catherine, how you managed this thing, or just observed?
This patient was managed by a follow-up with a retina specialist. He was coming from a little faraway place. So we asked him to have a checkup, regular checkup with the retina specialist at his place, and we had given the letter.
Okay.
Now, how will you classically, describe this finding? For the sake of the fellows, I'm asking.
Yeah.
Nice. Actually, how to describe? I was also thinking.
Bucket handle, sir. Bucket handle. Bucket handle.
Bucket handle. Bucket
Yeah,
handle tear is also,
described as a bucket handle.
Mm.
Bucket handle tear, actually.
Mm.
Yeah.
So usually it will occur in suprotable, no, sir, with this distortion. This is have you seen like frequently in infrotable areas, sir? Infranasal area.
This is
Sir, maybe other panelists can.
Yeah. Any idea about laser, like other panelists? Syed sir is asking. So Rima madam can tell, or Gajendra sir?
An observation would be fine, good enough.
Observation is fine, correct.
No, without any reason, why to do a laser? There is no obvious. Suppose associated dialysis or retinal break is there due to trauma per se.
Yeah.
Then the laser or prophylactic barrage is indicated. Otherwise, no treatment is required.
Correct.
To Dr. Naresh sir and all the colleagues, see, when we operate, we try so much doing vitreous based saving and all these things. If we could have done this thing during the surgery, just take out the vitreous base, our surgery would have been so much peaceful. So,
But sir, it is so tightly adherent. How to take it is,
yeah, exactly.
Abhijit, that's
So
why
much-
they tried this, I forgot the third block. The drug used for lysing the vitreous. What is that?
Ochriplasmin.
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 See, what happens is, like in all these cases, vitreous is otherwise called as, zonals are otherwise called as tertiary vitreous. So,
Mhm.
cause zonal lysis also, zonal lysis, and that leads to dislocation of crystalline lenses or the pseudophakic eyes.
Okay.
So, I think most of the time, I think in GRT, usually the vitreous is not adherent to the break, because the vitreous will be in the posterior, rather anterior flap, actually, posterior margin of the anterior flap. So I think the posterior edge of the posterior flap is usually, anterior edge of the posterior flap is usually free of vitreous, unless otherwise the vitreous is chaotic.
One more thing, Chitranjan, even though we observe it, they need regular follow-up. There could be other dialysis coming in the other sides, or detachment in the other area. If you can see this area, the nasal side upper part, there is a small dirty area.
Yeah.
That has to be
Correct.
observed very carefully.
Yes.
Yeah.
Very much right, sir. So one last question to Dr. Catherine. Who has taken this photo? You yourself or your ophthalmic photographer?
The photographer, sir.
Yeah, we must congratulate him or her, because it's not centered, because the disc and center of the fovea are little up in this image frame, but if we can see, the area of interest is very nicely focused over here. So again, all our viewers who are interested for capturing, or this helps in documentation, not only documentation but counseling the patient, or the patient goes somewhere else for the follow-up. So we should always focus on the area of interest, not necessarily the center of the fovea will be the center of the image always. This is very important. So you can share a chocolate or ice cream, something with the photographer. So again, yeah.
Why not the prize money, Chitranjan?
Price money is little higher, sir. So anyway, she can share.
You are so mean.
Yeah, correct. So again, congratulations, and see. Wins. I am apologizing because this certificate is misplaced over here. This is the first prize for Dr. Supreme. Dr. Catherine will get your certificate, proper certificate. Don't worry. Sorry for this. So we will go to the second winner, Dr. Akshat Kothari. And this is polka dot retina, what the harmless pattern he has captioned, and this is very very beautiful, and so many times these kind of images they have won awards, but don't think that they will not win awards further. So always capturing these beautiful images is always a pleasure, and this is a description he has given for this image. May I request Dr. Akshat Kothari to please describe the image. Are you there, Dr. Akshat? I think he is not there. So it's a benign familial flake retina, usually bilateral condition, as the name suggests, is benign only, and with the privilege of JS Clarus imaging system, we can take a very ultra wide angle image of these eyes. And any particular thoughts on this? Any of our panel? Rima madam.
Yeah, this is a very classical presentation.
Yeah.
Bilateral, I mean, they could have shown the other eye also, but this is beautiful.
Maybe he has submitted the other eye somewhere else and also won one award. That's why he has not given. That's also possible. So yes,
Ranjan,
yes, sir.
now without ERG, how can you say it's benign or what do you call fundus albipunctatus?
Correct. So yeah, so ERG is the diagnostic modality which will differentiate it from fundus albipunctus, which is the close differential in this case. And Sarah has told very rightly, and for all our viewers, especially young people, always keep in mind that is the close differential diagnosis, fundus albipunctatus. Correct, sir.
Or at least we could have done on HBF.
Which one, sir? Humphrey.
Field.
Humphrey field, correct.
Yeah.
Humphrey field also we can do.
But I think this is very classical of benign flake retina.
So any morphological differences, madam, or anything between the fundus albipunctatus and benign familial flake retina?
I think the lesions here, they have a
Yeah.
very typical, the
The distribution of the flakes over here, you mean to say?
yes.
Okay. Naresh sir,
The other
anything?
thing is the history of night blindness, Chittaranjan. These
Yes,
people
sir.
will
Correct.
not be having any night blindness,
Yeah.
unlike albipunctatus.
Yeah.
So that also will differentiate the
Yes.
diagnosis.
Yeah. Most of the times incidentally, just incidentally detected these days. Okay. So again, congratulations to Dr. Akshat Kothari. And this is the second prize for this beautiful image. He wins 3,000 rupees and the certificate. And we'll go to the first winner, Dr. Supreme Goel. So the octopus eye bit, that is the captions he has given for this image. And this is a case of GHPC. And they have followed up the patient and taken nice images. May I request Dr. Supreme to please tell about the image? Are you there?
Hello.
Yeah, please
Hello.
tell.
Yes, sir. I'm here. Am I audible, sir?
Yes, very much clear. Please tell.
Yes, sir. So this is a case of a 34-year-old female who presented to us 2.5 years ago with history of old choroiditis in right eye, treated outside with steroids, and now presented with complaint of diminution of vision in left eye for 1 week. And on examination, her best corrected visual acuity in right eye was 6.6 and left eye had 6.12 parts. And on fundus examination, as we can see in the clinical picture taken by IDON, right eye showed serpiginous choroiditis, like choroiditis patches, which are old with pigmentation and healed once, and sparing the fovea. Whereas in left eye, we can make out peripapillary choroiditis-like patches, which are continuous, and the temporal edge of the patch encroaching the nasal edge of the fovea. So, and patient had best corrected visual acuity of 612 parts in left eye on presentation. And after the investigations, blood investigations, and ruling out infectious etiology TB, so we started patient with on systemic steroids, IVMP followed by oral prednisolone. And now patient is being maintained on mycophenolate mofetil for now almost, patient has been on follow for almost 2.5 years now. And this AF was taken with when both eyes healed, because we can see there is no hyper AF on the edge. So suggesting that lesions have healed now, and patient is maintaining 6/6 vision now.
Correct.
Last, she followed up last on in October with us,
We'll
2025.
go straight away to Rima Madam for her comments on this, because she has maximum experience on this.
This is a very classical case of the autoimmune variety of serpiginous choroiditis. So very nicely documented and treated, Supreme. Congratulations.
Thank you so much, ma'am.
What's the age of the patient?
I'm 34 years old.
Okay, so patient is on immunosuppression right now?
Yes, ma'am. Currently on mycophenolate mofetil. Ma'am, reduced the dose, modified after consulting with immunologist, but yeah, still maintained. In between, during this course of 2.5 years, when we tried to taper the steroids, once recurrence started happening with a little IRF started showing on OCT, but then again, we at that time we hiked up the steroids, and now slowly we tapered off the steroids, and steroids were stopped, and patient is on mycophenolate.
So you must have ruled out TB, of course.
Yes, ma'am. Yes, ma'am. On the presentation itself, we ruled out.
This is very classical of the autoimmune variety of serpiginous choroiditis. Typically,
Yes.
papillary, no disc sparing, and the pseudopody ledges. Very nice. We rarely see it in India.
Correct.
And main thing is, how beautifully we can see the fovea is spared in the right eye, and left eye it's just partially involved with patient maintaining best corrected visual acuity of 6/6 in both eyes now. So that is something which feels like a.
That's why I've given this catchy caption to this image.
Thank you. Special thanks to my mentors in Chaitanya Eye Hospital, Dr. Manoj sir and Dr.
Just I
Krishnan.
forgot to mention that Supreme is from Chaitanya Eye Hospital. So again, congratulations. Thoughts from other panel, please. Dr. Gajendra sir.
Yeah, it is a beautifully pictured, and patient is lucky, sparing just a small island of fovea in right eye and having a good vision. Just want to know how long we have to give this immunosuppressant.
Yes, sir. That is something even I was thinking. So in between, in the beginning itself, we kept following patient very closely, because fovea was spared and there was always the risk of fovea wipe out. So we were concerned. So we kept, initially on the presentation, we kept close follow-ups, like 1 week or 3 weeks. So, and when we kept on monitoring, and when the lesion started healing, we increase the interval of our follow-ups, and when lesion was inactive, that time we decreased the steroids and shifted patient on immunosuppressant and started decreasing immunosuppression as well. Late.
Now it is almost 2.5 years. So how long you want to give? Another 6 months or more, or what? What is the normal?
Sir, we keep patient 3 to 4 months. We are following patient, but because of the risk of foveal, in between we stopped actually, but then recurrence started happening. So afraid of wipe off, so we had to restart.
I think what there's no definite protocol, but what decides is when did you have the last recurrence or worsening? So when you had to, what was the time when you had to hike up the dose again? So when we take that period, and then we probably go on to at least 2 to 3 years from that episode.
That is actually my concern. Worst case, it has to be continued till at least 2 to 3 years after last recurrence.
Another thing is, Supreme, we need to just keep a watch for CNVM, because they're very notorious for inflammatory CNVM on follow-ups.
Okay, ma'am. Sure. Okay.
So, Rima madam, in case of CNBM in these eyes, you go for the traditional anti-VEGF for combination with steroid also?
No, if it's only CNVM, we go for anti-VEGF. Unless there is a recurrence of inflammation, the lesions are also worsening, then we hike the steroids. But if it's only CNVM, anti-VEGF.
The
Traditional.
choice of anti-VEGF?
Any choice of anti-VEGF, madam?
Ranibizumab.
Ranibizumab. Okay. So, okay. So, Abhijit sir, any comments on this, Abhijit sir?
Yeah, it is. Photo is nicely taken, and whatever Rima madam told is what basically got enriched. But we face few patients like this. These patients, no, in practical life, they are basically practically what you call that. They don't have the mobile vision. Basically, severely feel restricted, like
Yeah.
the stage RP, like, and we feel good. We just tell patient, and we just say that you are lucky you have your 6/6, but they are never happy that way. And another thing is that how you are taking, I mean, what you call that, following up whether it is recurring or not. You cannot do OCT all around the edges of the scar. So maybe sometimes you may have to do some ICG with FFA to see that you don't get much more, what you call, widely spreading out.
No.
They suffer like anything. Basically, what happens, their field will be drastically cut down like it is a 5 degree like that.
So I can answer your questions, Abhijit. So one
Mhm.
thing is if the patient is very troubled with restricted vision and all that, so make them and their relative see these fundus, project these fundus photographs in front of them, and tell them that how the normal fundus looks like and what their fundus is like. And when you tell them that despite all this, the patient is able to read so many lines, so they are convinced. Secondly, we don't have to do OCT at follow-ups because OCT has a lot of, this shrems and atrophy, so that's not a good imaging. Autofluorescence is the key. And in the autoimmune variety, the advancing edge is usually like the pseudopodal edge. So if the lesion is advancing, you will see one of these pseudopodal edge, getting hyperfluorescence. That's typically known as the bulb appearance of the autofluorescence. So autofluorescence is the key to detect a recurrence or a worsening.
Do you think, madam, that ATT has some role? Because
No, so this is the classical variety, the autoimmune variety. So she said
okay.
they ruled out TB test. And usually the TB variety of serpiginous it leaves a rim of juxtapapillary area free. It's not this kind of contiguous to the optic disc.
Yes, ma'am. It's more in the periphery also multifocal rather than this.
Multifocal, and plus even if the disc is involved, there is a rim of juxtapapillary area which is generally free. It's not
Correct.
contiguous to the optic disc.
So we had nice discussion on this differentiating between autoimmune versus the infective varieties of
You
this.
must publish this, Supreme, as a photo essay. Yeah, this is very rare. In India, you don't see. You should label it as
Thank
something
you, ma'am.
like
I will actually
classical
put my mentor for yeah. That will
And
be nice.
herpetogenous choroiditis in an endemic country, right? So this itself speaks of the rarity of this entity in our region.
yeah.
Yes, ma'am. Actually,
So
serpentinous like variety might be more common
No, no,
because
no,
of.
no, no. Don't write serpiginous like.
Okay. Okay.
Classic serpiginous choroiditis in an
Okay.
endemic country.
okay.
Okay.
So, Syed sir, one last question to you on this image. Like your threshold for starting ATT in this kind of eyes, like even though the diagnosis towards autoimmune, what is your opinion? We should go for the traditional, the steroid and immunosuppressives plus ATT, or it's we don't need it? Syed sir.
We used to start a trial ATT, then if we want the other investigation, we'll take a call. Recommend to other results are positive, then we'll continue with ATT. Otherwise, we'll go for steroid immunosuppressant.
Okay, correct. Okay, so final comments on this, Naresh sir, please.
Nothing, Chitranjan.
Okay.
Okay, I think we have to apologize for overshooting the time by 10
overshooting the time. So yeah, so congratulations, Dr. Subrin Goyal, for this first prize, 5,000 rupees and this certificate. And again, congratulations to all the winners. And I must thank all our members of VRSI Image Committee, Dr. Naresh sir, Dr. Unni sir, Dr. Vinod sir, and myself. We are there in the committee, and I must encourage all our colleagues and request all the seniors to please encourage their juniors to please submit images in large numbers and very good quality images to our VRSI image competitions. And I must thank the panel this evening with us, Rima Madam, Dr. Gajendra sir, Dr. Sayed sir, and Dr. Abhijit sir. So, any last comments from Dr. Naresh?
Chittaranjan, you can ask the panelists to motivate their fellows and the SRs to submit
Yes.
images.
So a special request to all our panelists, because all of us will know that you are all senior people. Many young colleagues, juniors are getting trained under you. Please encourage them to submit images, and you have all witnessed and encourage all our winners also. So I'm sure that you will have a very good image bank with this kind of images. So please encourage your younger colleagues to submit images. It's very simple. With the help of Numerotech, I must thank Manjula Madam, Prem Kumar, and Sai sir, their Numerotech team. We have actually simplified the submission process of the image and the text description for this. If you have any problem, you can always reach out to us. So please submit a good number of good quality images.
So I have a question. This is only for VRSI members, right?
No, it's open for all actually. But the
Can the
voting will
ophthalmic
be
technicians, because I believe they do so much of hard work, can they submit?
yes.
But they're not VRSI members. Is
No,
that okay?
maybe I think they can send in the name of some ophthalmologist.
No, but the credit would go to the resident or the senior resident or the ophthalmic technician.
Madam, as of now, we have made like
Actually, they
one.
are the ones who are taking these.
That's why you would have seen many of the like the jellyfish image or these Vitas based
Thing is by them.
Yeah.
We
So that
can help them give the caption, but the effort is by them. So why can't we promote them? I mean, because they don't get the authorship in articles and
No,
images,
this
right?
this is a very good idea, madam. We'll take care next time, maybe in this.
But I think the people who are submitting, they should credit the images to the people who
Yeah,
are taking,
correct.
rather than we telling them actually. So it is a sort of, I mean, it should come
Or
from the
can
people
we
who are
just
presenting.
edit when they are submitting the image?
Yeah.
The presenter is the retina specialist, and
Yes,
there
we
is
can do
there
like
is
that.
one more step when they are submitting, that the photograph is taken by so and so ophthalmic technician.
Yeah, we can do that.
We can do
A good
that.
suggestion.
Where
Or
the
at
ophthalmic
least,
technician will be acknowledged.
yeah, correct.
Definitely.
Correct.
I think that's a good suggestion. We'll definitely take it.
Devikunda ko aata.
Yeah.
Definitely.
Because as of now,
You
sir,
have
we
to
are
take
having
care, because you
we
have
are
to
having the
take care, then
provision
there is no.
of we are having the provision of giving the award to one person, and because ophthalmologist, why ophthalmologist? We are asking questions. As you can see over here, sometimes we ask questions to a particular ophthalmology. Maybe that person may not be in a position, then that will not be good. That's why that is
No,
actually.
Chittaranjan, the thing is not about the answering. What she's saying is there should be recognition for the person who has actually done the work.
Yeah, we'll make it as.
So maybe I think we can have some photographers, certificate at least, to acknowledge their work. We'll do that, definitely. We'll
Appreciation
discuss it. We'll
certificate
definitely.
or
Acknowledgement will do, ma'am.
100% will do that.
Will do. Very good suggestion, ma'am. So,
Any final word of motivation from any of the panelists to the young
yes, sir,
who are presented? Otherwise, once it is over, we can call it the day.
One
Anybody would like?
suggestion from me also.
Yes.
Abhijit,
Please
sir.
go ahead, Abhijit sir.
These photos, we are keeping it in a bank in VRSI websites.
No, Abhijit, we are not doing that because see, then it becomes the copyright of VRSI. Then the number of people submitting will become less actually, unlike the other places. So it's a free, I mean, for them, because you will be getting more recognition when it is published as a cover page of some journal. Actually, see, we don't want to restrict that. That's why we are not holding any copyright, and we don't want to have any the
Image
image
bank.
bank as of now.
Okay.
But Abhijit sir, all these award-winning images are there in the VRSI website. If we go to the VRSI image committee, all the like today's ceremony, it is all getting, documented and recorded. It will be there, and also the award-winning images with the descriptions will be there in the VRSI website. We can see. But as you are asking, like we get so many images submitted, we don't keep all the images. As Naresh sir told, that is the important reason. Otherwise, people will not submit. Why will submit to VRSI? I'll submit somewhere else. That is the reason. But the award-winning images are there, definitely there. All the years we can go, every month we can see in the website.
I think in the last session, one of our image was actually accepted for cover page, so it was retracted from the images contest. You remember Chitranjan?
Yeah.
So that way we don't want to hold any images. People will be getting more recognition if it is printed on the cover page of or accepted as photo essay or something like that.
Yeah.
So any final words, Abhijit et al.?
Yes, Gajendra sir, you want to say something?
No, sir. I just want to. Patients are waiting, so I have to finish my OPD.
Yeah,
So I
please.
just want to take permission to say bye, everyone.
So yeah,
and thank you for the opportunity.
Yes, sir.
Thank you for the opportunity.
Thank you.
Bye-bye.
Thank you, everyone, and we'll close this session today.
Yeah.
Thank you.
Thank you very much.
Thank you.